a pleasure to welcome you back to another episode of Medicine and the Machine with my co-host Eric Topol. We are really delighted to have as our guest someone who's really made such an impact on the world, and that is Dr. Seth Berkley, who is CEO of Gavi, the Vaccine Alliance. I got to meet Seth a couple of years ago, but heard him speak at a TED conference well before that, and I've just been blown away by the breadth of the impact he's made on the world. He's a physician, he's an infectious disease epidemiologist. He joined Gavi, the Vaccine Alliance, as its CEO in 2011. And in its existence, Gavi has reached more than 820 million children in 73 of the poorest countries, vaccinating them. In his first 2015, or rather in 2015, in the second replenishment to the Gavi Fund, they managed to raise $7.5 billion in donor commitments. And not surprisingly, Dr. Berkley is also co-leading the vaccines pillar of the ACT, the Access to COVID-19 Tools Accelerator, working to distribute the COVID vaccine. Prior to this, in 1996, Dr. Berkley founded the International AIDS Vaccine Initiative, the first vaccine product development in the public-private sector partnership. He has really been involved in global health for so many years, on the cover of Newsweek magazine, recognized by Time as one of the Time 100, the world's most influential people, written extensively, traveled extensively throughout the world. And Seth, it's such a pleasure to have you join us here today.
Thanks so much. Great to see you. I shouldn't say anything because it's such a nice introduction.
You've had such an incredible career. I know you began medical school at Brown and went on to Harvard for your residency training. Did you chart out a course that would be like the one I just described, or how much of this was happenstance? How much of this was design? Tell us a bit about the trajectory of your career.
Well, it's interesting. I started out, being passionate like you are about medicine and taking care of patients, but I also wanted to do as much as I could. And I got drawn to infectious diseases because, obviously you can get quite sick and die from those diseases, but you also, if you can turn them around, you can often get people back to their normal states. And then once I started working on infectious diseases, of course, the biggest burden was in developing countries. And then as I began to work on that, I began to get interested in thinking about it from the public health perspective, because how to have the maximum influence. And lastly, vaccines became, a point of fascination for me, because it's probably the tool that has done more to, maybe that and sanitation, to change health of people around the world. So it's been a kind of, I certainly didn't plan it this way, but it has had some logic to the way it's progressed.
And for our listeners who don't know as much as I've managed to learn about Gavi, tell us a bit about Gavi's origins and what it's really managed to accomplish in all these years.
So, many years ago in the 70s, less than 5% of children in the developing world were vaccinated at all against the, small number of vaccines we had for common diseases. And so that was considered a tragedy. There was an effort to get vaccines out, and it got to close to 80%. That was considered a success, but afterwards people kind of stepped away from it. And in the meantime, new and powerful vaccines were being developed with the best of science, and they weren't getting out to the places that you could argue needed them the most, to the developing world. So the premise for Gavi was, could we create a public-private partnership that would work to take these new technologies and go from having them be high-cost, low-volume production to high-volume, low-cost production. And on that, we've been quite successful. We've introduced 496 new vaccines in the poorest countries of the world. And with that have driven down the price. I mean, an example would be the WHO recommended vaccines now cost, if you had the equivalent in the US, about $1,300. We procure them for $27. And, we continue to try to drive that cost down so that we can get maximum access for these products.
That is truly amazing. My co-host Eric, as you know, is a cardiologist, but somehow he knows more about vaccines than most infectious disease people I've known. He's certainly kept abreast of all this, and I know we're both dying to ask you, what is the strategy for bringing this vaccine, the COVID vaccine, or its many iterations to the global community?
Well, first of all, let's go back to time, and if we have a minute, maybe we can explain the last effort. So the last effort was quite interesting. The last effort was we had an Ebola outbreak. It occurred in an isolated area in 2014, kind of on the confluence between three different countries in a place that didn't really have a health system, and as a result, it was misdiagnosed for months on end, and then eventually it spread into urban centers, spread widely, and it really was. All the previous outbreaks had been a couple of hundred, but this one went into more than 10,000 people. It was really quite a serious outbreak, and what was interesting is there were early attempts at Ebola vaccines because people thought it might be a bioterrorism agent. So people stepped up with vaccines, but the challenge was, how do you create a market for those vaccines? And so what we did at that point was said, listen, we'll put money on the table. We put $300 million on the table, said we would go ahead and purchase vaccines if a manufacturer would create vaccines that would work. And, long story short, eventually it led to the Merck product that is now in a stockpile and has been used since multiple times to deal with epidemics. Now, the reason I use that example, the problem there is there was no market for vaccines. With COVID, of course, we had no idea whether we could make a vaccine and how long it would take. But the science has been breathtaking, and we can talk about that in a minute. But what's really interesting is it became quite clear early on that the problem wasn't going to be there's no marketplace. The problem was going to be is that everybody wanted it. And therefore, what would likely happen is that wealthy countries would buy up all of the doses of vaccine, and there would be none for the rest of the world. And that's not a good thing. It's not a good thing from a humanitarian point of view, but even more important, when you have a global pandemic, we're only safe if we're all safe. And if the virus is still circulating uncontrollably in different parts of the world, you can't go back to normal. And of course, you could end up with problems with new strains appearing, as we've begun to see now. So this really was about how do we create a global distribution of vaccines. So it's the exact opposite problem as Ebola, and that was the challenge that we tried to deal with. So we created a facility called the COVAX facility, and we divided it into two parts. One, we went to the familiar places, the poorest countries, the countries we normally work, but this time we expanded the number from 73 you talked about earlier to 92 because we included a number of small island economies that would have problems and a few slightly richer countries. So those were countries which would be, our traditional customers. But we also said if self-financing countries might be interested in joining COVAX, we could work together. And we had no idea whether there'd be interest, but we ended up with 98 self-financing countries joining. So at the end, we had 190 countries come together in a short period of time saying, we'd like to work together on trying to make sure that there would be equitable access of vaccines.
Well, Seth, I don't know if there's anybody who's more grounded in the planetary landscape of vaccines than you. It's really quite extraordinary. There's so many things I'd like to ask you, but I guess in the COVAX world, the U.S. is not participating, which is, I find, very upsetting and objectionable. What have been your thoughts about that?
Well, it's interesting. The U.S. has been an extraordinary supporter of Gavi during its entire time. And even the current administration, was very generous, gave us an increase for this last replenishment. Abraham talked about our previous one, but we just had one that was really extraordinary that raised, about $1.4 billion more than we asked for to try to expand the work that we're doing. And the U.S. was very generous. But at the end, the U.S. had decided it would create its own program and moved forward. Of course, we've been in contact. We've been discussing with them because, of course, the important science work they're doing. But we were very happy to see over the holidays here that as part of the last supplemental bill, the U.S. government provided $4 billion for COVAX. And so, in a big way now, the U.S. is the single largest supporter of the effort to provide vaccines for developing countries. So I have to say that, the U.S. took a little bit longer perhaps than some of the others to engage, but now they are substantially engaged, and we look forward to continuing to work with the U.S.
I think part of the problem is there's a lot of vaccine nationalism, as I think you might agree, where many countries are only really worried about their own population and supply. But obviously this is a world challenge, because if we don't get the majority of the population of the planet vaccinated, we're still going to have, we're going to probably have COVID as endemic anyway, but we're not going to get containment. Can you comment about nationalism versus worldism?
Well, Eric, it's a very good point. So if you were to rationally design a program for a disease, if you remember, this started as a point outbreak. Within a few months, it was in 180 countries. And so when you're dealing with something that is that infectious and moves from country to country, and what we also learned, by the way, is that when a country was able to dampen it down, if it relaxed, often it would be people either traveling out and then getting infected, or people coming in and starting another infection. So the idea that you have, one isolated community that is going to, be protected and the rest of the world is not going to be, and that it's going to be safe, is not something that is the reality of the infectious disease world. So to your point, it's important to say, from the humanitarian reason, that we should try to support countries around the world. But in this case, it's actually self-interest, because if you want to have travel and tourism and commerce and the ability to engage with the world, and if you don't want new strains to be, developing, what you really want to do is make sure you dampen down the disease everywhere in the world. And so I think, to me, that's really the biggest argument why we have to have a global solution for what is clearly a global problem.
And I think you mentioned COVAX, but can you get a little more granular as to exactly how do you distribute vaccine in these countries, and how do you identify who gets vaccinated? We can't seem to do it state by state within the United States. So I marvel that you're going to do this at 90 plus countries. Is it the
190,
same? 100, forgive me. There you go. So how do you do that? Do you have one size fits all, or is it?
No, of course not. And what's so interesting about this is, in essence, you put some guidelines up, and I think the guidelines would be uniformly clear. So from our perspective, health workers are the priority first. Why? Because they're taking care of the sick. If they get sick, they have to have a lot of absenteeism. Obviously, if they die, you lose talented workers, and the health system gets overwhelmed quickly. So we believe that health workers everywhere. So the first goal for COVAX is to try to let countries vaccinate their health workers. And that's going to vary. I mean, some wealthy countries may have a higher percentage of the population. Some poor countries may have a lower percentage. We can be liberal in what we define as health workers, but that would be what our recommended first priority are. Then we would go to the high risk groups, and that's going to vary. So obviously the elderly are high risk, but comorbidities. But when you go to countries that have a much younger demography, and you have, different refugee groups, if you look at the US, you might say, risk groups are those working in nursing homes and people, in prisons, or people in, meatpacking plants. But, in a developing country, that might be people in an urban slum, or people in a refugee camp, or a displaced set of persons, and so I think countries will have to adapt and adjust their strategies. So what WHO has done is put guidelines out for what they think are the priorities for doing this in a stepwise fashion. And then, countries will ultimately make the decisions internally. So the way we work is, of course, we don't vaccinate anybody. We support countries to do the vaccinations. And in this case, a country applies to COVAX and says, we want doses, and here's what we think we're going to do, and here's our state of readiness, and here's what our cold chain is like, and here's what the supply chain is like. And then if that is all acceptable. It's looked at by an independent review committee. Then we provide the vaccines. If it turns out that something isn't right, or the review says we don't think you can do that, of course, that's not like a grant. You don't reject them. What you do then is say, okay, how can we help you strengthen your cold chain, strengthen your supply chain, do some more training so that you can get these doses out as soon as possible.
One thing you mentioned, I think you used the word breathtaking, which I couldn't agree more, as to the rapid validation of extraordinarily high efficacy vaccines, namely the 2 mRNA vaccines. And now that sets a very high bar for the subsequent vaccine reports. Of course, some that we're still waiting for, some that have come along without much transparency, some with murky results that range from 62 to 90, whatever. How do you sort this out as far as the efficacy? And do you think there's something special about this mRNA platform that's making it distinct just by appearance?
So first of all, I'm a great fan of novel technologies, and certainly, if you look at the mRNA platforms, they've been very exciting for a while. I actually made a special trip up to Moderna before COVID was even on the horizon, just to see the technology and the possibility of using it for outbreaks, for quick things. And I think when I say it's breathtaking, I mean, if you look at it, the previous vaccines, 4 years was the shortest vaccine we had ever made. The average vaccine, 10 to 15 years of development. And here you had, in 42 days, you went from sequence to the first vaccine in a vial, 63 days to the first injection in humans, and then about 330 days before you had an efficacy trial result of a serious sized efficacy trial. So I think the compression has been extraordinary. Now, the mRNA vaccines are exciting in terms of the way they work and the way they stimulate the immune system, but there are many other technologies that perhaps take a little bit longer to get started. And so I suspect we will see efficacy results that are, similar to those levels from other technologies, given what we know about. We don't yet know a correlate of protection, but given the way these vaccines are constructed, I think we can expect to see that. Of course, it isn't true until we actually see the data, and the data is clear. But and then you have to ask the question, okay, well, are there going to be products that are more attractive for use in different settings? So, for example, the J&J vaccine is right now being tested as a single dose vaccine. That would make a real difference in terms of being able to use it in a campaign mode versus having a follow-up period. There are other vaccines that, also are easier to use from a temperature stability point of view. There's going to be other vaccines that are incredibly inexpensive in cost. And so I think one of the things we'll have to balance is both efficacy, but also ease of use, and also the economics of it in terms of global distribution. The last thing I'd say is, of course, we don't know how long these vaccines last for. So we don't know if this is going to be about having one large campaign to cover a large enough percentage of people and that's it, or if we're going to have to go back and reboost people at some time frame, or even that we might have to do this on a regular basis. And of course, now that we're seeing the amount of variability that's occurring, will we need different vaccines? Will we have to adjust the vaccines in a sense like we do with flu to, adjust it for new variants that appear? At the current time, it doesn't look like that, but these are all science questions. And what's extraordinary is that we're rolling out vaccines around the world before we even know, for example, how long the shelf life is of the vaccine. So today, instead of putting this vaccine expires at this date, you can't do that because they haven't been out long enough to know how long they last. So instead, they're now stamping it and say this vaccine was produced on, and it's almost like, please check back regularly and see how long it is stable in the bottle as we do those tests. So a lot of really interesting new things are being done this time.
Stay with us. We'll be right back with Medicine and the Machine.
Welcome to Medscape's latest podcast series, Medicine and the Machine, featuring Medscape's editor-in-chief, Dr. Eric Topol, and master storyteller and clinician, Dr. Abraham Verghese. Remember, you can find the latest in medical news, expert perspectives, clinical tools, continuing medical education, and more at medscape.com.
So what is COVAX doing in terms of which vaccines you pick? Are you just taking the ones you're able to get, or are you selecting particular ones for particular countries?
So the idea was to create a portfolio, and that was particularly important at the beginning because we had no idea whether any of these approaches were going to work. And luckily, it seems that different approaches are working. We've so far seen the mRNA vaccines work very well. We've now seen vectored platforms, and Eric talked about some of the differences, although today I think we have a pretty good understanding about why there are some differences there. The one group we haven't seen yet are the protein-based vaccines, the adjuvanted protein-based vaccines, and those in the preclinical models and in the immune studies look very promising. So, there's going to be, and then of course there's lastly the inactivated products, and we've seen a number of those come through, and recently have had some results reported, although they haven't been published yet. So if it turns out that all different types of vaccines work, then we could take a mix of those based upon the quantity and the ability to produce. Because remember, if you want large quantities, even if you have one that you really like, you can't make that one everywhere. It's going to be very important to have multiple producers. But the other thing we try to do is, as we look at new candidates, we ask the question, what's missing in the portfolio? What would make a difference? And so, for example, a single dose, as I talked about, would make a difference, or a vaccine that had a much better result in the elderly, or a vaccine that would be much more stable at, or stable at room temperature, or could be given, orally. So what you ask for each vaccine after a certain point is, does it add to the portfolio or not? Does it serve a certain problem? And if it does, then we want to look into it.
One of the questions, I'm sorry, Abraham. One of the questions that I had is that, people talk about the priority schedules, like healthcare workers and the elderly. But interestingly, when the phase 3 trials have been conducted, they go to hot zones. They go to places where there's lots of infections so they can see and get a readout on efficacy quickly. And wouldn't it naturally follow, with you looking after the world here, 190 countries, wouldn't you prioritize to put the vaccines in the hot zones of those 190 countries? Because that's where they're going to do the most immediate good, rather than the issue of age and healthcare workers and on and on.
It's an interesting question, Eric, and you have to look at it from an experience point of view, because if you think about it, in the past, we've had outbreaks. This has particularly been true with flu. And if you go back to the 2009 swine flu pandemic, what you saw is that people said, gee, we have to go into these places that have the maximum number of cases. But often those places had a case curve that was up near the peak of the curve, and it was starting to come down. And the effects of the vaccines in those communities then turn out to not be as helpful. Whereas if those vaccines can get to places where you're before the curve takes off, they can have maximum efficacy. So the question, at the beginning was, is this going to be just in a few places, or is it only going to occur, through, one set of outbreaks? But what we've seen now is waves of outbreaks. So I think, at least from what we know about the epidemiology now, is that you'd want to go out and try to protect. The reason health workers are important is that if a wave of cases come to a country, having the health workforce know they're protected, and if you can then deal with some of the highest risk groups who would be the ones who would fill those hospitals and overwhelm the health systems, you at least then, do everything you can to protect that health system. And so, but this is something we have to do through modeling, is to try to understand over time how this is going to work. And if we see antibody levels, cell-mediated immunity coming down, then we're going to have to think about whether we're going to need, booster doses, et cetera. But it's too early for any of those information. So in a sense, we're out trying to vaccinate acutely to try to stop the pandemic, not necessarily to understand, right now what the long-term strategy is going to be.
You have a much better sense, I suspect, than most people as to how things are on the ground in many of these different countries. I've been struck that the amount of devastation I expected to see with COVID in, say, sub-Saharan Africa and in many African countries doesn't appear to be as much as I had feared. And I don't know if that's poor reporting, or is that an actual observation that the disease is somehow either less prevalent or causes less morbidity there. We had a guest on the show a couple of weeks ago who speculated that, to some degree, in villages where people walk, there isn't the that kind of spread. Do you have any thoughts on just the prevalence in those countries?
Well, first of all, the honest answer is, we don't totally know, because the amount of testing going on in most of those countries is well below that in most other parts of the world. That being said, we've seen in countries, severe outbreaks that have led to teaching hospitals having, people piled up, sick, pneumonia cases, people dying, morgues overwhelmed. And we haven't seen that in most countries. So my guess is you're not missing, a huge outbreak. Now, why might that be? Well, to one point, it may be harder to transmit, but also, if people spend more time outdoors, the temperature is such that you don't have as much indoor gathering. You also have, different age demographics where, half of the population is less than 18 years of age. And so that may have an effect. But what's scary about all of this is that, South Africa had cases, but they weren't that severe. And as you know, there's now been a new variant that's appeared there, and it also seems to spread much faster, just like the variant that was seen in the UK. But right now, I've been told, I haven't myself traveled there, but that their intensive care units, their hospitals are becoming completely overwhelmed with these cases now, and that is a real problem. So I think that, one of the questions here again is, if you try to stay ahead of this and guess where it's going to go and what's going to happen. I mean, initially people thought, well, maybe in the tropics it won't cause infections, but you've seen India has the second largest number of cases in the world, and we've certainly seen other places that have had severe disease. So I think we need to just basically say, as of today, anywhere is potentially at risk. Of course, it may be worse in some places than others, and with the new changes occurring in infectiousness, this could change further.
Yeah, I'd like to just get into the variants a bit more with you, Seth. The B117, as you mentioned, was seen in the UK, and this, Y501 South African variant. They both have this infectiousness increase. The actual magnitude is, whether it's 30, 50, 60% is not entirely clear, but they are really becoming dominant quickly. So in Ireland, in just a few weeks, they went from 9% to today 45%. And now Ireland is the number one new cases per capita in the world. And it's like a vertical line. So even though, as you pointed out, these two variants or strains, if you will, are not likely to interfere with the vaccine efficacy, at least in a substantial way, they're clearly going to be competing, at least at the moment, to become dominant strains around the world. And so this new wave, this new challenge, can you comment about this? Because this is actually, just looking at the Ireland plot today, it's pretty scary. And we know the UK is in a pretty similar shape, and other countries as well. And of course, as you're well aware, we have this in the US. It's at low frequency, but it's certainly going to be on the rise.
So I think the first thing to say about this is we can't become complacent. Now, what is the way to deal with this? It's obviously to use the same non-pharmaceutical interventions, perhaps with even more strictness than we did before. But as you know, this has been a cycle of tightening, relaxing, tightening, relaxing. And if you relax with a more, hyper-transmissible strain, you will see increasing numbers of infections. And of course, the worrying thing is how this plays out in, for example, school children, where they may not get sick, but if you have strains that are much easier to spread, they may become, a foci of transmission through families and moving this along. So I think these are some of the concerns that we have. Of course, if we had vaccines available everywhere for adequate populations, the first thing you'd want to do is vaccinate everybody you possibly could, because the quicker you bring down the susceptibles that exist, the faster you'll be able to stop that spread of disease. But at the moment, there isn't enough vaccine. So it's really going to require, people redoubling their efforts to try to do prevention where they can, to test and trace and isolate and do all of those efforts. But I think the reason it also is a lesson for us is that if people kind of thought, well, we'd have a wave, and as you know, there was a whole set of discussions on herd immunity and all these kind of things. I think what we're seeing here is that you do not want to leave this virus unattended and not dealing with it. And anybody who says, well, it's just the flu, it isn't. And it's not only not that from death rates, but also, we're going to have to deal with the serious complications that we're seeing afterwards. We don't fully understand those, but large percentages of people are having residual, long-term side effects and morbidity that's going to be very important in the years going forward.
Mm-hmm.
You probably have the world's most experience with distributing vaccine in different populations. Talk about the US, although I know this is not where you normally do distribute your vaccines, but what about the strategy so far for distributing vaccine, and what might you advise, say, the Biden administration and that advisory group going forward?
Well, I mean, I think, what's interesting is that if you look at developing countries, they have a lot more experience coming in and rolling out, outbreak-based vaccines and campaigns and doing those activities. And so, the secret to doing that, as you can imagine, is, just a few simple things. One, having a national plan to do that, and having it, as well planned out as you possibly can, with almost military precision. Secondly, is having acceptance of the vaccine. And so having, people comfortable that this is important, that this is something they should do. And that requires your community engagement and your religious leaders and your politicians and others to be on message to help people, do that. And then, third is very careful follow-up. If there's any adverse events or any problems or any miscommunications that occur, that you're there to dampen them down quickly. So, we've done lots of these, and if you go to your home country, well, not where you were born, but where you were educated in India. I mean, we did, measles-like campaigns for 300 million people. I mean, so it's, these are extraordinary campaigns, but they have to be well organized. And I think, in a very fragmented system where there's not a standard way of working, it becomes much more difficult. And then if you get down to each different state, each different district, each community has a different way of working, of course, that can create confusion from messaging and even from where people go to where do you report problems if you have, or how do you deal with the rumors. So I think we're seeing different models occurring in different places. And the more we can move to having some type of aligned approach with everybody working together, the better we'll be. And I think, in a sense, this is what's happened in Israel, where, you've seen I mean, yes, it's a small country in size, but they've operated with, kind of a whole of government approach and really have moved quicker per capita than any other country in the world.
Well, yeah,
Go ahead.
The fact that they've gotten over 70% of their people over age 70 already vaccinated there is extraordinary. But one thing I was going to ask is that, we've been talking about shots. And I guess the thing that's surprising to me is there aren't mucosal immune vaccines. We know that the vaccines—
There have been a few.
Right.
We have some that we use.
For COVID, I mean.
Oh, yes.
Yeah. So as you well know—
There are some in development, it's just
right.
They're not ready yet.
Yeah, I want to get tabs on that with you, but as you well know, the vaccines so far haven't really been assessed for achieving sterilization or mucosal immunity. There's some encouraging data from both Moderna and a bit from AstraZeneca's work, but we don't know. And possibly, be good, but it won't be 100%. And we'll have these asymptomatic carriers who get a vaccine. So I wonder, why is there not more priority to get, as an adjunct, even if not a primary vaccine, because this would be so easily administered? Why don't we put the turbocharge on getting those out there? So can you tell us where we stand with these inhalation vaccines?
So what's interesting about this, of course, in this case, it was absolutely move as quickly as possible with the technologies you had available. Luckily, some of the new technologies were technologies that were particularly well suited to this. But as I said, there's a whole generation of vaccines, multiple generations coming. There's now, more than 250 vaccines in the pipeline. And so in that are, for example, live attenuated vaccines, which may be very attractive in terms of long-term immunity and single dose, et cetera. But there are also a number of nasal vaccines and oral vaccines that are being used. And so I think we will see these move forward. They are logistically a little bit more difficult to produce because there hasn't been as much experience with them as compared to parenteral administration vaccines. And obviously, if you're trying to use vaccines that have, that are live-based vaccines, there's sensitive issues in terms of safety and proving attenuation and all of that. But I think we'll see those coming up. And the question is going to be, do they provide better protection? What's interesting, if we look at polio, this has been a debate that's gone back and forth because the oral polio vaccine gives you mucosal immunity, and therefore it's great for using in outbreaks, but it also can transmit to others because of the fact that it is a live vaccine, whereas the inactivated vaccine protects the person, but doesn't provide mucosal immunity and doesn't give community, protection in that sense. And so we've used both of those vaccines in an outbreak setting, in a sense, like you talk about, to both protect individuals, but then try to deal with this. In terms of whether vaccines will be, all of the ones were studied for disease sparing as the, and looking at severe outcome of disease. There hasn't been as much study yet on whether they're blocking of infectious transmission. And part of that, again, has been, given the situation, what people were concerned about initially was trying to, protect against severe disease and death as the priority. But those studies will go on and are very important because they may be differentiation between different approaches, which may be better for public health use.
So my last question is really about the UK's strategy, controversial strategy of just using up their first dose, the second doses that they were saving for the whole population. What is your sense of that decision?
Well, it's a complicated answer, but I will give you an honest answer. If you go back to what Eric talked about at the beginning, the AstraZeneca data, there was a subset of analysis that had 90% infection rate. The overall cohort had 70% and then 62% in the two full doses. That group that had 90% had 3 different changes associated with it. It was a half dose to start, and that was an error in doing the titers for the vaccine. But when they figured that out, there was also a delay in the time of giving the second dose, and there was also given to those under 55 years of age. So initially, when it was announced, people said, we don't really understand which of those there are. But now that the data has really been looked at, it is quite clear that if you look at antibody responses to the vaccine, they go up dramatically if you go 4 weeks, 8 weeks, 10 weeks, 12 weeks, and you see a much, much higher antibody response when you boost at a later time period. So the problem the UK has, in a sense, is that the trial was done for a 4-week interval. So that's what, in a sense, the approval is. From a policy making point of view, it is pretty clear that that dose interval is probably what makes a difference. And we know from the Johnson & Johnson vaccine, the Ebola vaccine, that they did very careful dosing studies. It's a different adenovector, but they were able to show a longer dose interval gives you much higher protection there. So, I mean, this has scientific credibility and with other doses as well. So what the UK therefore is saying is, although the data is really only there for the 4-week interval for a regulatory approval, the overall data suggests that a longer interval is better. And from a policy point of view, a longer interval allows you to distribute the time and give more doses. So I think in a sense it's logical, but of course what you want to make sure is that they actually do the study to validate that that is actually correct. And that'll have implications not just for the UK, but for the whole world, because given the shortage of vaccines, we would also love to be able to vaccinate and have a longer time period, do what we call a 1+1, give a dose and then at a later point give a booster. But if the regulatory approvals are for short time intervals and we don't have any scientific data to do that, that's really problematic then to recommend to countries, because of course it may be that you don't have as good protection in the interval between the two doses. From a public health point of view, that may be okay, because if you have double the number of people vaccinated, you may get a population immunity that's better, but from an individual perspective, they may be at more risk. So lots of complexity to this, and we really need the data, of course, to be able to answer these questions.
Well, Seth, you're an incredible resource. I mean, you've got the anchoring of all this other vaccines over decades and the whole worldview. So maybe you can tell us your prognosis for getting out of this mess. Are we going to do it? When are we going to do it? Obviously, it's not confined to any country. It's a planet story. What do you think?
Well, of course, I'm an optimist. I think that by the end of 2021, we will have vaccine in every country. We will have at least the critical groups vaccinated. And I think that's going to move us more towards normal. But of course, we will not have enough vaccine to get herd immunity, full population immunity. But once you have that type of effect going across the world, I suspect that will change the epidemiology. We don't know totally what that's going to look like. Now, of course, that'll mean that we probably still, when we travel, when we have exposure, we'll probably still need to use non-pharmacologic interventions, but it may put us in a much better place. Now, of course, what I can't predict is, are we going to have new strains that are worse? Or are we going to have other problems? But I think one silver lining for all of this, and it's really important, is it is evolutionarily certain that we will have more outbreaks. After all, the population is going up. We're putting stress on the environment. We're cutting down forests. We're living closer to, wild animals. Climate change is going to shift massive amounts of population. And so what I'm hoping is that this time, this is a wake-up call for the world to focus on being prepared for outbreaks. And that's about having resilient health systems. It's having surveillance. It's trying to study in peacetime, transmission among animals, and making sure you have vaccine manufacturing facilities ready to go. All of that really could help us. So when next time it happens, we're better prepared than we were this time. And we do that in many other areas, and we put a lot of effort into, preventing things. And the challenge for us is that infectious diseases, people tend to think they're all taken care of, they're all done, but we know that's not true. And this is something that I think we really have to work on going forward.
Seth, that's a wonderful, optimistic note to end on. We can't thank you enough for being with us. I think our listeners really would have learned a lot, and I'm so glad that they are learning about what Gavi has done. We'd love to have you back. I'm sure there's going to be much more to talk about as we get more vaccine experience. So please keep some dates on your calendar in the future for us to revisit with you. Thank you so much for giving us your time, and I thank my co-host Eric for, as usual, my partner in crime here, and asking such incisive questions.
Oh, thanks so much, Seth. Phenomenal.
Thank you so much, and thanks for having me. And I look forward to continuing the conversation as we learn more about the disease, more about the vaccines, and how we do what Eric says is move us back towards normality.
Amen. Thank you so much.